So what I'm going to is to make you familiar with the current treatment options in terms of minimal invasive therapy. The learning objectives are found in our syllabus. We have seen that already from Pablo. These are the figures around for Europe. As you said, the colorectal cancer metastasis is one of our major playground for testing and evaluating local ablative therapies because they are so common. We know that in the advanced stage, we see an increased number of even if the stage itself is the minor stage among the other three stages, but in this stage we see the distant metastases, and these are mainly located in the liver. So the task of all the treatments, if it's surgery or if it's our treatment attempts or the classic chemotherapies, is to increase this column that the survival is much more higher than right now, because at that stage the survival is determined by the remote metastases, not by the primary anymore. So if we look at the oncologist's view, and this is from a not unknown oncological institute, the Wexner Medical Center, this is a very simple approach. It's only chemo and some maybe some biologicals. At least we find they make at least a differentiation between resectable and unresectable, but nothing more. So, and even in this flowchart from the same recent paper, they consider local portal vein embolization to make a liver resectable, but no other local ablative therapies. I was surprised by this concept that nothing else is there considered, even not in the text. But this, I think, is nicely reflecting the perspective of many oncologists worldwide. If you go to oncological meetings, this will be a pretty common experience. So we have to find a very open-minded group of oncologists to even to discuss additional options for them. Now, if you look at something like this, you could get the impression there is no evidence for local ablative therapy and only for resection. So, but if you go for surgery, then we have a resectable disease only in 10 to 25%. This does not mean cure. That means that a surgeon makes the decision that he or she is going to do surgery on the patient, not talking about the outcome. And still, the resection is considered to be the gold standard. And I think nowadays it's one of the only techniques that never was tested for their evidence. It's the concept saying, if I cut it out, then everything is fine. But this was never controlled by a randomized control trial. Interesting concept. The 5-year survival, depending if you pull data from the literature, between 20 and 60%. Local recurrence rates, moderate. Perioperative mortality in modern surgery, I think, is quite low. Liver surgery is well established. And there's also an expanding role with all these data in the background. If you go for liver surgery, even if you have metastases with local lymph nodes, maybe these are not really playing a role for the survival. We do not have really studies right now giving an answer to that. No, but maybe there is a little bit more. This is the classic surgical way. This is, everybody knows from telecolleague at night. We learn almost every night on TV how to treat these patients. But this is our armamentarium. But I won't talk about all these because I try to pick out the ones that are established. So PI is not for metastases. Chemoperfusion, because there's some kind of new advent. I will touch on these. Chemoembolization is, again, a revival there. Stereotactic radiotherapy, there is microscopic evidence, even if the radiotherapists really want to enter that field. But in the liver, it's not that easy, and the results are not that convincing that are there right now. Radioembolization, we learned a lot and heard a lot about here on the ECR. And then the major field of thermal ablation. LIT is almost out of the game. IRE, I think there's no play for, not a real playground for IRE. Cryo can be done, focused ultrasound can be done, but they have all to compete with the excellent data I will show you for the classic high temperature thermal techniques. One thing to keep in mind is that all these minimal invasive interventional therapies act mainly locally, but always fit into a more multimodal, more comprehensive therapy concept. So there's no need for a fight. It's an excellent add-on. And where can this add-on be used? So we have different scenarios. This was one task, to define some scenarios. We have the classic patient that is really not resectable. Which strategy? The classic strategy would be chemotherapy, but we have many patients that are resistant to the chemotherapy that can't stand it anymore. Potential resectable patients, if there wouldn't be this metastasis in the left liver lobe, is there be a potential of downsizing? I won't touch because a completely different topic on PV, portal vein embolization, to make one liver lobe grow. Only we'll talk about the local ablative techniques that might allow this. And then the classic resectable one, is this really a candidate for resection, or is this also a candidate for local ablation? Let's start with chemoembolization, and there the breakthrough the last years was the advent of calibrated particles, and even very tiny particles that can be loaded to enhance their efficacy. But let's have a look about the classic therapies. Hepatic artery infusion plus systemic chemotherapy in colorectal cancer metastases. Median overall survival, there are not that many, let's say, sophisticated studies, but you see that was not reached, 18 months, 18 months, 18, 19 months versus this regimen. Response rate quite nicely in all of them, but the patient basically is not really interested in response. The patient asks you, if you have the patient in front of you, how long will I live? This is the major question. The second is, what will be the quality during this period of life? Response rates, they are not really interested. So this is from looking at some putting the papers together and creating a meta-analysis, and we look at old papers, old meta-analysis papers from '96, and these we have to think old techniques in interventional, old techniques in chemotherapy, not a real convincing survival. But even with these more modern techniques, it's 16 months versus 12 months, and even this could be overridden with modern chemotherapy. So high hepatic artery chemoperfusion right now, even if there are papers are presented and new small studies are presented, there's a revival of it, but the data are not again convincing. So we should leave that to studies right now. How about chemoembolization, adding an embolizing agent to the chemotherapy? This is again a very recent meta-analysis, and you see tons of different regimens were used. The major thing is there is not a really modern one, and this reflects in the overall survival. So this is much worse than what we could reach right now with FOLFOX6 or FOLFIRI plus antibodies is almost double the overall survival what we can reach in comparison to this. So in the old TACE regimens, they are outpaced by these new concepts of antibody therapy, so that we can interimly state there is some kind of a revival with new techniques, new tools, new particles, eluting particles, new chemotherapies that might be combined. So we have to see what in this combination is possible. But the classic case, there is no evidence for colorectal cancer metastases. Now, what is now with these loaded particles? Irinotecan can be loaded in most of the few that are available. This is a recent study, and the response rate was quite nice, even admitting this is only 6 and 12 months. This is about your stable 11 metastases after 4 months. So this is not really that convincing. Typical case for that, this was 40 micron particles loaded with irinotecan, and you see the growing zone within 1 day gets devascularized and necrotized, but this is only anecdotal findings right now. There's also a very recent review from end of the last year, and still, if we look at these, the median overall survival is not that convincing. It's still, in the best case, in the lower limit of the range, what the best systemic chemotherapy plus antibiotics can gain right now. We have to think of the regimens that were used in these studies. So again, drug-eluting beads, depending on the drug that is connected to the bead, has to be further investigated in further studies, like in this meta-analysis again from Fiorentini. So this is still not meeting the data we can reach right now with the most modern chemotherapies. So again, classic case, lacks of systematic data and standardization, that's a problem. So the question is will be the new case? And many studies are dealing with that issue. And the key issue is, are there potential benefits if we combine now the new and every 3 to 6 months arising new, coming onto the market, new drugs and antibodies with this type of therapy? Now, if the chemotherapy is not working, how about radiotherapy? Percutaneous radiotherapy in colorectal cancer is a challenge, because you need, for an adenocarcinoma, 70 to 80 to 90 gray to kill it by radiation. To get these radiation doses focused percutaneously means to burn a hole into the patient, and this, in most of the cases, even if you're applying this in a hospital as well, with stereotactic and cyberknife radiation, it's really a tough task for the radiotherapist, and maybe even a tougher task for the liver. So why not using this technique by like an old technique like brachytherapy? And the Y90 radioembolization is nothing else like brachytherapy, using the brachycath, the internal vascularization of the liver. So this is a study just from Konsti Sophocleo from New York, and Nancy Kemeny, where they were looking as a salvage therapy, confirming old data. It's a small group, and they could not really convincing present data with the local progression-free survival and the general progression-free survival. But this, as an end-stage therapy, they could gain a survival for more than 1 year. And this was found in many studies before. One example for that, this was also an end-stage treated patients after chemotherapy with all these metastases all around the liver. And this is the 3-month control with no active metastases afterwards. So do we have evidence for that? And in the meantime, we have evidence. I put it together for the salvage situation in chemorefractory, pooled data for non- and colorectal cancer metastases. And what you can see is that with adding radioembolization at the end, we are about doubling the survival time of the patient. How about second-line therapy? It's almost the same, but we have to look what type of chemotherapy was used in that time. So this is not the most modern one. So again, if we add this in this stage, modern chemotherapy, make a change to modern chemotherapy, they might end up with prolonged survival times. But how about first-line therapy? And maybe that's the most convincing one, because many factors are now influencing the survival. It's also the liver function, and in most of the studies, nobody's really talking about the loss of liver function under polychemotherapy. And again, it's about adding in the very first line radioembolization. You will be able to double the survival time or the proportion of patients that will have a prolonged life in comparison to pure alone classic and modern chemotherapy. So if you put that together in comparison to, at least in that studies presented, chemotherapy or best supportive care, it's about always doubling the survival in comparison to chemotherapy alone. There are some additional interesting side effects where we can use it. Contralateral hypertrophy of a liver lobe that is not treated in cases where you do a separated single lobar radioembolization. And there is a quite interesting increase of the size, resulting at least in some resections. Of course, this is you never will be able to make a study with these patients. So if you analyze your radioembolization cases, your patients, and you will discuss the patient in a tumor board, then it will be clear that there will be a patient saying, okay, we didn't expect, we did a salvage treatment or second-line treatment. Now we have a completely different situation. We have to re-evaluate the patient. Maybe now the patient is eligible for surgery or ablation, local ablation, thermal ablation. But these data from many small studies and mid-sized studies are telling us there is a potential to change the stage, the hepatic metastatic stage of the patient to a better field. Now, let's come to the area where we where we have to compete with the intention to treat the patient in some way curative way in comparison to surgery. Now we're talking about thermal ablation, and there's tons of generators, machines, RF ablators, microwave ablation systems. Some of them are not on the market anymore. But the goal is to kill the tumor definitely by applying a lot of amount of energy with temperatures above 100 and even more, 150, 160 centigrade. And if we go back now in really old study, back to 2000, even in that study comparing RF versus resection in small tumors, there was no significant difference already in that study, interestingly provided by a surgical group between thermal ablation and resection. So this was encouraging many of us to go further in that field. Even from that time or a little bit later, still the same pros and cons and positive or negative prognostic factors for RF in colorectal cancer were defined. And these are the number of tumors, so not that many tumors, even if I show you a little bit counteracting data later on. And even the presence of extrahepatic disease does not play a role, but this elevated CEA level and the tumor size. And this is still the critical issue. Now, if you look at the very nice meta-analysis where many data were collected, we could find that as a single therapy without the chemotherapy, without surgery, we can derive from this data for 5-year survival rates between 20 and around 50%. So remember, one of the first slides, these are the same results like surgery. Now there are data where we're comparing RF versus resection, but we have to think how will be, and we will touch that in a second, how will be the selection criteria. And again, these are poor data and these are better data. Could be something to do with the selection. Let's have a look at this data from a surgical group. And in this, if they put all patients together, then the resection is doing better in terms of radiofrequency ablation. But if we now take the patients out that have only 3 centimeter metastases, then there is no difference. So again, it's an old thing. Selection is the key for the treatment. Also in this case, first-line RF in patients that would be amenable for colorectal metastases, no difference between resection and thermal ablation. How about the number of the metastases? Because there's also a change in the paradigm in surgery. Because also in the beginning it was saying, okay, up to three metastases, maybe even 2 lobes can be done surgery. Now aggressive oncological hepatic surgeons, okay, if I get the lesion, that's fine, it can be 10. Is that true? In this study, a very recent one, they tested resection versus ablation, and up to 4 mets, the isolated resection was doing better. The resection plus ablation was doing worse. Why they were the same when they were treating more than 5 mets? A little bit confusing for me, because I would argue maybe they haven't done sophisticated imaging. Maybe they did based on CT, not on MRI, not on PET. This is not really clear, but this is the most important information. So you can achieve the same survival in surgery if you do a decent workup and a decent treatment for each single lesion. And we have data, for example, from UK, from Alice Gillham's, where there's not really an upper limit if the treatment is, if the lesion is treatable. And this is the text out of the paper. RF versus resection versus cryo. RF and resection behave again the same. Cryo is not yet in the game there. So in this also very recent paper, this was not really recommended. And this is a summary of the data we have seen, and the green ones is always in favor of surgery. Now why? If you now look at this paper, how you have to interpret them, then this was a retrospective analysis with 12-minute ablation. Everybody who is doing ablation knows this is too short. If you stick to the protocol of the vendors, you will always under-ablate. The same true for this study. We know that for where, and we're discussing this extensively. Monitoring with ultrasound. This is the weakest technique you can use because you lose the insight in your lesion and what you're doing. So this is a programmed failure, and no overlapping in unresectable disease with huge lesions. They did a single positioning and did then in my eyes, a too short ablation, and without overlapping positioning of the needle. It's programmed failure of the procedure. So we are comparing real apple and peaches. How about complementary? So it's not something to fight something out of the game. If you're combining this, and this is also from a very recent study, also again from a surgical group, saying, okay, basically there's no significant difference. Think of the number of the group that could be resected only by resection. So the majority, they needed RF ablation to get the patient resectable. So it's getting, this is maybe the danger for the radiologists, for the interventionists. So RF or thermal ablation is getting a surgical tool. So if you combine this now, RF with the multimodal therapy, means polychemo surgery to the right moment, do the right, we are ending up again with 5-year survival of 45%. Systemic chemotherapy versus systemic chemotherapy plus RF, the same, doing significantly better in the combination therapy, even if this study was not really powered for creating a difference. But we have a prolonged disease-free survival and overall survival. Also in this Italian study, multi-center trial, 63 median survival in the group with no local tumor progress, going down to the patients that were not treated, at least with a 31-month survival. Now, putting this data together for RF and microwave 5-year survival, overall data we have is about 55%, and this has a little bit to do with the patient selection with 68% with microwave. One case for multimodal therapy, radioembolization now with RF ablation. This patient was after polychemotherapy radioablated. We have a significant shrinkage of the tumor, and finally the remainder, the residual tissue was then radioablated. So there's no issue to combine all this therapy as long as the rest of the body, the rest of the liver likes to play within this game. You know, similar charts from treating the HCC. The Hamburg group created something very nicely for colorectal cancer metastases. Normally, this is the classic way, resection or non-resection, and then tons of chemotherapies and antibodies. Now, in between here, there are in the resectable area, there fits the thermal ablation concept, and also in the non-resectable, combining with the other therapies, and we need maybe more evidence, but I showed you the data that are out there, and it's not that view that we can switch the patient to the resectable stage, and then resection means there can be, at least in tumor sizes up to 3 centimeters, there seems to be no difference in doing resection or thermal ablation. No, summing up, image-guided ablative liver mets therapy is safe, easy, and effective. I avoided all this data on safety. You know, it's a very safe procedure, less than 2% risk of complication. All these techniques, and maybe even the transarterial techniques, are gaining again an important role also in colorectal cancer. Metastases are available tools that the existing classic chemotherapies might extend this classic oncological armamentarium. And the results, I hope I could convince you with that, are comparable with the classic established oncological therapy. And I'm pretty convinced that all these therapies are potential cornerstones in what is one of the issues right now in modern medicine, in individualized therapy regimens. We have a comprehensive cancer center. The interventional radiologist is a permanent part of this game, and is often the first ask for his treatment options. Thank you very much.